Sabay-sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, may laban sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Ilang dekada pang tayo'y magkakasama, sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala't kwento natin ng katuwa at pighati, sa lahat ng pangyayari na naghubog sa atin.
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary healthcare in the era of universal healthcare. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Good afternoon to everyone on Zoom and those watching the Facebook and the UP Manila live streams. Before we proceed, let me introduce myself as your moderator today. I am Dr. Janie Saure, one of the Silver Jubilarians this year from the UP College of Medicine class of 1998. I am a medical specialist in 2 of the 3 DOH hospitals in Region 2, namely Cagayan Valley Medical Center and Southern Isabela Medical Center. I also practice as a general and pediatric surgeon in Tuguegarao and in the province of Isabela. But enough about me. Allow me to introduce our esteemed guest speaker, Dr. Maria Pamela Patdu. Dr. Patdu is a medical oncologist practicing at the Asian Hospital and Medical Center. She is a member of the UP College of Medicine class of 2007. Today, she will update us on the breast cancer gene and its role in disease. Thank you, Dr. Patdu, for taking time out to join us today.
Thank you very much, Dr. Saure, for that kind introduction. Thank you for this invitation to talk about the BRCA gene and its implications in breast cancer. Let me share my screen. Okay, so today I will be talking about BRCA mutations in breast cancer. This is a very broad topic, but we'll more or less focus this on its relevance in breast cancer. Here are my disclosures. And as a disclaimer, this is a non-promotional lecture supported by AstraZeneca, intended for healthcare professionals. It's going to be a very simple talk. I'll be first introducing and more or less reviewing BRCA mutations. And the most important part here is why should we be testing for BRCA mutations? And we will also be talking a little bit about BRCA mutation as an indicator of prognosis and disease course in breast cancer. So first, the BRCA genes and the BRCA mutations. So BRCA mutations are mutations in the BRCA gene, and the major BRCA genes are your BRCA1 and BRCA2. These are tumor suppressor genes. They encode the proteins involved in the repair of DNA double-strand breaks via the homologous recombination HR pathway. Just as a quick segue, we know that DNA damage can have several repair mechanisms. So you can have single-strand break repair, and another important pathway is your double-strand break repair. And in this repair, the more consistent, more reliable mechanism is your homologous recombination pathway as opposed to your non-homologous end joining repair pathway. And it is in this pathway that BRCA1 and BRCA2 proteins play a lot of roles. So BRCA1 and BRCA2 proteins regulate cell growth and prevent abnormal cell division that might otherwise lead to tumor development. So in the context of double-strand repairs, BRCA1 induces repair proteins such as RAD51, PALB2, into the repair mechanism, while BRCA2 is very much critical in loading the RAD51 in this process, and among others, no. So there are many functions. There are many overlapping functions of BRCA1 and BRCA2. We note that these genes were among the first genes directly linked to cancer and remain two of the most studied genes. While there are differences in their structure, they share numerous interacting functions. So often, it is referred to as the Angelina Jolie gene. In 2013, after finding out that she had BRCA1 mutation, if you recall that time cover, the actress publicly opted to have a double mastectomy as a risk-reducing procedure, and this was done publicly to continue to raise awareness for testing of breast cancer. And even before this, just as a brief history of BRCA, in 1940, Sir David Smithers demonstrated that breast cancer could occasionally run in families with several generations being affected. And as we knew more about genetics, it became clearer that hereditary cases of breast cancer were caused by a faulty gene, and it was dubbed breast cancer 1 or BRCA1 in 1990. This was followed in 1994 by the discovery of BRCA2 on chromosome 13. Okay, so it is worthwhile to note that BRCA mutations can be either germline or somatic. So when we talk about germline BRCA mutations, the inherited mutations are found in all body cells. So it can be detected in blood or buccal swab samples, where you have your epithelial samples from your cheeks, cheek lining, and of course your somatic BRCA mutations, which are acquired mutations found only in the tumor cell. So somatic BRCA mutations can be detected in a tumor sample, whether it's fixed formalin paraffin embedded or frozen samples. Next, so germline BRCA mutations would increase the risk of developing different types of cancers. While we often think about breast cancer, it's important to note that it can increase the lifetime risk of several cancers. Most notably, it's most known and studied are your ovarian, prostate, and pancreatic cancers. You can see here a table of the lifetime risk of developing cancers of these four-mentioned cancers in the general population. And if you compare it to those who are harboring germline mutations of BRCA1 and BRCA2, you can see that in breast cancer, there's a very big difference. So there's a higher risk of breast cancer at about 55 to 65% among BRCA1 mutation carriers and 45% in BRCA2 mutation carriers. If you look at ovarian cancers, it's a little bit lower, but still, you can see from here an increased risk of BRCA1 ovarian cancer in BRCA1 at 40%, and to a lesser extent, 11 to 17% for your BRCA2 mutation. But note here, if you look at pancreatic cancer, in the general population, you have a low risk, but you can see that those who are harboring the BRCA1 mutation have a 2 to 4-fold increase. And it is even higher in your BRCA2 mutants, where you have a 5 to 10% chance. Prostate cancer also is of interest. So in those who are harboring BRCA2 mutation, you can see that is higher compared to that of the general population at 20%. And if you look only among patients with unselected breast cancer, the prevalence of germline BRCA mutations is approximately 5 to 10%. Shown here is a graph of the different prevalences of germline BRCA mutation in unselected breast cancer populations. There might be some differences, but overall, it's about 5 to 10% of patients who have germline BRCA mutation. This is something consistent with what little we have published in the Philippine data, where it is said that among breast cancer patients in 2009, 5% of patients would harbor germline BRCA mutation. Now, the percentage of patients with germline BRCA mutation also varies by breast cancer subtype. This diagram shows us the different subtypes of breast cancer. Shown in blue or blue outline are your triple negative breast cancers. Your magenta is your HR positive, HER2 negative breast cancer, and the rest are HER2 positive or unknown status. You can see from here that among the blue ones, the triple negative ones, 17% of patients with TNBC have germline BRCA mutation. In terms of percentage for the HR positive, HER2 negative breast cancer, it's lower for the HR positive, HER2 negative at 7%. However, if you look overall in the absolute values, while this percentage is lower because a lot more patients are HR positive, HER2 negative in absolute numbers, you actually have more patients with germline BRCA mutations, which are the HR positive, HER2 negative compared to your TNBC. So the next question is, knowing that indeed germline BRCA mutation occurs in your breast cancer patients, particularly in triple negative and your HR positive, HER2 negative breast cancer, why will we be testing for germline BRCA mutation? So this is the take-home slide. This is one of the most important slides here. Why should we be considering testing for germline BRCA mutation? First, it determines early decisions in the treatment of breast cancer. So these decisions would include surgery and systemic treatment. So what is meant by this is, upon diagnosis of early breast cancer, when you have the decision as to what type of surgery to do, whether this is breast conservation, whether this is mastectomy, then the decision might be influenced by whether there is BRCA mutation status or not. Beyond that, the option of contralateral prophylactic mastectomy is there also, and knowing the status of the BRCA mutation might help in terms of decision making. Knowing that the patient is at increased risk of contralateral breast cancer might offer more options for the patient and might offer reasonable means by which she could decide on prophylactic mastectomy. Further, it can also inform their future care and establish whether they are at risk of developing other cancers. We already earlier outlined that BRCA mutation, germline BRCA mutation increases the risk of other cancers such as pancreatic cancer and ovarian cancers. And in terms of determining the risk of these patients, the monitoring, the screening and other interventions to lower the risk, such as oophorectomy to lower the risk of ovarian cancer. Knowing the germline BRCA mutation helps plan out these patients diagnosed with breast cancer. Next, it's not only the patients. It can also help determine whether members of the patient's family are at increased risk of developing cancer. But having said the benefits of germline BRCA mutation testing, it's important for us to note that testing will always be optional. No? And it will be something always at the discretion of the patient. Okay, so germline BRCA mutation testing should be conducted early to aid treatment decisions. Shown in this diagram are the treatment pathways for early breast cancer, advanced breast cancer treatment. And of course, we also see here your family implications. So for early breast cancer on diagnosis, the germline BRCA mutation testing is needed upfront, particularly to inform surgical decision-making, breast conservation, and prophylactic contralateral prophylactic mastectomy. And now, in this day and age, it also helps inform chemotherapy and future targeted therapy decisions. So you can have adjuvant treatment beyond your chemotherapy with your PARP inhibitors in certain high-risk patients. Also, it can also inform chemotherapy. So in terms of neoadjuvant treatment decisions, for example, for BRCA mutation carriers, they might be benefiting from platinum chemotherapy. And of course, beyond the treatment, you have your survivorship in monitoring your germline BRCA mutation patients for cancer. They must be offered means of risk reduction, and that would also include your prophylactic of bilateral oophorectomy. In the advanced breast cancer treatment, you can also see that upon diagnosis, knowing germline BRCA mutation status would be very much helpful, because even in the first line setting, germline BRCA mutation can be an option in terms of deciding first line treatment. So, and as in your early breast cancer setting, monitoring of the patients for secondary cancers and offer risk-reducing strategies are important measures also. And of course, family implications. So one of the indications for doing genetic testing for those who do not have breast cancer will be to have a first of kin was already an identified BRCA mutation. And these patients are often referred for counseling. And when they do consent for testing, this consenting can be cascaded to other family members as well. And screening or monitoring of both male and female relatives can be offered. And for those who do choose to have germline BRCA mutation testing, and they are found to have such mutations, they are offered risk-reducing measures. Knowledge of BRCA mutation status prior to surgery is important in terms of guiding surgical decision-making, as earlier alluded to. So, risk-reducing strategies such as contralateral mastectomy may be offered over partial mastectomy or unilateral mastectomy for patients who are germline BRCA mutation carriers. There's still a lot of need for more data on how it influences reduction in terms of survival, but still, this patient can be offered this risk of reducing recurrent or new breast cancers. Also, because of the risk of ovarian cancer, removal of fallopian tubes and ovaries at some point after diagnosis, depending on age, family planning, hormonal status, and ovarian cancer risk, should be discussed with patients. There is a difference in terms of when the prophylactic removal of the fallopian tubes and ovaries or salpingo-oophorectomy is offered in BRCA mutation BRCA1 carriers, often it's at 36 to 40 years old. And for your BRCA2 mutation carriers, it's often offered at 41 to 45 years old, or for both of the mutations upon completion of family. So family history can help identify patients who may have BRCA mutations when this information is available. So this graph shows us the impact in terms of the prevalence in the patients with a history of family history of breast or ovarian cancer. For instance, if you have a family history of 3 or more females with breast cancer, all diagnosed 51 years old or older, it's probably lower as compared to having 2 female relatives with breast cancer and one of them being diagnosed before 51 years old. So it's almost 20% in that setting. In another setting, when you have patients who have a family history of ovarian cancer in at least two relatives, that's about more than 40%. Similarly, the prevalence with one female breast cancer relative and one female and at least one relative with ovarian cancer is a little above 40%. So the more relatives, the younger the relatives are on diagnosis, you can see it has an impact in terms of the chances of having BRCA1 or 2 mutations. So having said that, we now see the treatment guidelines actually recommend testing not just in those with a family history of BRCA-related cancers. So traditionally, a lot of the recommendations are based on the personal history of breast cancer and the history of family history of breast cancer. But if you look at present guidelines, it also now integrates consideration of the impact on the patient's risk management, particularly if you look at the NCCN guidelines there, it is said that it can be used to aid in systemic treatment decisions using PARP inhibitors. Of course, shown here also are your usual recommendations when we will do BRCA mutation testing. So you can see here, all patients with breast cancer diagnosed at 50 years old or younger. And of course, patients who have, all patients, regardless of age, with triple negative breast cancer, lobular breast cancer, or with Ashkenazi Jewish ancestry. And of course, the presence of a relative with breast cancer at age of less than 50, male breast cancer, ovarian or pancreatic cancer, and of course, a diagnosis in at least one relative with high-risk prostate cancer. The list goes on, and if you look at the ESMO guidelines, there's a lot of similarities as well. For metastatic breast cancer, it outlines also that germline BRCA mutation status should be assessed as part of the routine clinical practice in your HER2 negative metastatic breast cancer. In real-world studies, it shows a significant deficit in physician-driven referrals for BRCA mutation testing. So I've talked to you about the benefits of mutation testing, its impact on the patient's management, and in terms of advising family and their risks. But how far have we gone in terms of BRCA mutation testing? Here shown are real-world studies, and you can see that a lot of the regions would have less than 40% testing. Overall, the data is less than 60% for those who are guideline eligible in terms of physician testing. The outlier there is Israel. If we just look at Israel, they have free testing for BRCA mutation for those who are at risk. So I think that drives why, as compared to the others, they have higher testing rates in Israel. And they also have a population of Ashkenazi Jews, which have been shown to have a higher rate of BRCA mutation carriers. So In terms of BRCA mutation testing rates, we can see. So we mentioned that we do testing for your triple negative breast cancer patients and your HR positive HER2 negative patients. We can see historically it has been lower. So the first in the cluster would be in 2015, and then the next is in 2017. And after this, you already have approvals for your PARP inhibitors like olaparib, which has an impact in terms of systemic treatment of early breast cancer, of metastatic breast cancer. And then the data in 2019 and to 2020, you can see here that the third bar in each of these groups are much higher. It looks like the opportunities to affect management has affected also the rates of testing of BRCA mutations. If we compare the HR positive, HER2 negative with the triple negative breast cancers, however, you note that there are higher rates of testing with triple negative breast cancer. We have seen in the guidelines there are broader recommendations for testing for triple negative breast cancer, and this probably explains that. Also, maybe the message that a greater percentage of TNBC patients are TNBC as compared to your HR positive, HER2 negative. But the message today is that even if there's a greater percentage of TNBC patients having germline BRCA mutation, we must note that in absolute numbers, there's actually more patients with BRCA mutation in your HR positive, HER2 negative. And we should be doing testing for these patients where indicated, as we have earlier discussed. So how do we actually do the germline BRCA mutation testing? It's the most widely used method is to use a blood sample. So DNA is extracted and DNA analysis is done whether there is germline BRCA mutation. So there are now a lot of labs and hospitals that offer BRCA mutation testing. A lot of them still send it out, but I think we in UPPGH, I think we have local capability to do this BRCA mutation testing. When we do this test, what will we be expecting of the results? So the results may come out in one of these three. So it's from class 1 to 5. They can be classified as pathogenic. So you have your class 4 is likely pathogenic, and then you have your class 5, which is definitely pathogenic. And then you have the middle ground, the uncertain. The term is variant of unknown significance. And the next is your non-pathogenic. So class 1 is not pathogenic. Class 2 is likely not pathogenic. What is clinically actionable, where you can probably apply PARP inhibitors, where you can probably recommend risk-reducing strategies, are the ones in the left, your pathogenic, your class 5 or class 4. But note, the variant of unknown significance is something to take note of. No? So, when talking to the very few genetic counselors in our country, they would recommend, in fact, that if you find a patient with germline BRCA mutation with variants of unknown significance, that they should actually be referred to the genetic counselors. Why? Because it's important to know that this classification is something that is evolving. That several years from now, this classification might be reclassified to be pathogenic. And that has implications in terms of advising patients on risk-reducing strategies, in terms of monitoring the patients. Hence, it's important not to ignore variants of unknown significance. In my clinical practice, I actually see a lot of patients where I feel they already have a pathogenic BRCA mutation, but they will turn out to have variants of unknown significance. It's important to know that this is based on a wide database of mutations. And if, let's say, a particular race is not doing a lot of testing, we might not be catching this and classifying. We might not have that much data to classify it as pathogenic. But if in the future, with further testing, with further databasing, we see that this variance of unknown significance is something that can be reclassified to pathogenic. A lot of the platforms now for BRCA mutation testing would have a live document to update these results. And it's important to take note of that. Next. BRCA mutation as an indicator of prognosis and disease scores. So patients with germline BRCA mutation have distinct disease characteristics. To simplify this, germline BRCA mutation carriers are compared in this figure to sporadic breast cancer. So those who are mutants, germline BRCA mutation carriers, will have a younger age at diagnosis of breast cancer, and their breast cancers will likely have a higher grade, and they have a higher CNS metastasis rate, and more contralateral or ipsilateral disease. So if you look at this diagram, you can see that the BRCA1 mutation carriers are often diagnosed in the range 35 to 44 years old as a median. For BRCA2, the median is 40 to 45 years old. Both BRCA1 and BRCA2 mutation are diagnosed earlier than your sporadic breast cancer patients at 54 years. And if you look at the histology, you might want to ask, what kind of histology does the BRCA1 or BRCA2 mutation carriers usually have? In studies, it has been shown that majority are invasive ductal carcinomas. This is true for BRCA1 and BRCA2. For BRCA1 carriers, there is a lower incidence of invasive lobular carcinoma at 2.2% as compared to your BRCA2, where you have about 8.4%. Another study would have consistent results where 92% of the tumors were actually having a histology of invasive ductal carcinomas. Now, if we look at the grade, so in breast cancer, often we know of the characteristic biology of the breast cancers based on several factors. And the simpler tests are looking at the grade of the tumor and your Ki67 gene expression. On the graph on the left, it shows us the division from grade 1, grade 2, and grade 3. You can see that for grade 1 and grade 2, the higher percentages are seen in the sporadic breast cancers. But if you look at grade 3, which is the more aggressive grade, you can see that a large percentage of your BRCA1 at 89.6% and BRCA2 at 74.1% are actually classified under grade 3, suggesting it's more aggressive biology. And if you look at the graph to the right, which looks at Ki67 gene expression, again, a signal of the more aggressive pathology, you can see similar to grade 3, the BRCA1 mutation and BRCA2 mutation carriers have higher percentage, again, suggesting the more aggressive pathology of germline BRCA mutants having breast cancer. Now, if you look at brain metastasis, you can see higher rates with your germline BRCA mutants as shown in the left graph. You can also see that the time to first brain metastasis is much earlier and usually occurs in the first 2 years for your germline BRCA mutants. As to patients with BRCA mutations, do they have increased risk for ipsilateral breast cancer or contralateral breast cancer? Yes, in a meta-analysis, it has been shown that ipsilateral breast cancer in patients with BRCA mutation had a relative risk of 1.51. As for contralateral breast cancer, the relative risk is more often, the hazard ratio is 1.58 when we talk about differentiating BRCA1 and BRCA2. But overall, it's observed that BRCA mutation carriers have increased risk for contralateral breast cancer. So now, after having discussed contralateral and ipsilateral breast cancer, what else do we have showing us the characteristic of germline BRCA mutation carriers with breast cancer? They also have higher risk of recurrence scores. So one of the testing platforms in early stage breast cancer, you might have heard, will be your Prosigna using 50 genes. It tells us that when BRCA1 mutation carriers and BRCA2 mutation carriers were compared with those of wild type, they had a higher risk of recurrence scores. This is also true for your harder endpoint, disease-free survival. You can see that those with BRCA mutation has a worse recurrence-free survival and distant metastasis-free survival compared to your non-carriers. And they also, for BRCA2 mutation carriers, they had significantly shorter disease-free survival than your BRCA mutation carriers at an HR of 1.35. When we compare BRCA2 with BRCA1, we can see that the BRCA2 mutation carriers had a kinder breast cancer with a median time to relapse of 63.6, much later than the BRCA1 mutation carriers at 23.3 months. However, the overall rates of relapse were similar between the two. Now, we mentioned earlier Prosigna, looking into early breast cancer recurrence score. This slide tells us about another of the recurrence scores, your Oncotype DX recurrence score. It is often used as a prognostic and predictive tool for your early breast cancer patients in terms of looking into the benefit of chemotherapy and, of course, prognostic value. Here, it has been shown that those who have BRCA1 mutation and BRCA2 mutation as compared to non-carriers would have a higher median recurrence score. So in Oncotype DX, the higher the score, the higher the risk of recurrence, and they are the ones who are likely also to benefit from chemotherapy. So the left and right graphs are more or less showing us similar figures. These are two different studies. Now, while we presented to you how aggressive the pathology of breast cancer, when we look at these studies, often we must interpret it in the context that somehow there are limitations to these results. Some minor limitations will be your unscreened, we might not be screening all the BRCA carriers also. Because of the lower prevalence of BRCA mutation carriers, a lot of the studies that we've been discussing have small sample sizes, and the inclusion of BRCA untested are also part of some of these studies. And of course, while we have done a lot more about genetics, about BRCA mutation, we recognize that there might be unknown clinical or pathologic factors that are not considered in the adjustment for the results. And of course, because breast cancer is a very dynamic treatment landscape, there are a lot of treatments already for breast cancer. The studies might not be factoring in the presence of what kind of standard of care or the absence of the present treatments in that analysis. And this is something that we should take note of. So in summary, when I talked to you about BRCA mutations in breast cancer, we outlined how those with BRCA mutated breast cancers have distinct tumor characteristics generally characterized to be more aggressive. And treatment guidelines at present does not only limit the recommendations for screening to those with a family history of breast or ovarian cancer. We also noted that in the recent years, the recommendations extend to which of the patients would benefit also from knowing the BRCA mutation if they will benefit, let's say, from systemic treatments like PARP inhibitors. And despite confounding factors in the studies on BRCA mutation outcomes, it's important to identify patients who have BRCA mutations early, whether this is in the early breast cancer setting or in the advanced breast cancer setting, because of its impact on management and its impact in terms of advising their family members. So, just as a final take home, consider genetic risk assessment for the following patients: early onset breast cancer, triple negative at any age. Of course, those with history of ovarian, pancreatic, or metastatic prostate cancer, your BRCA-related cancers, and a personal history of or family history of breast, ovarian, pancreatic, and prostate. And of course, always, it's a red flag when you see a male breast cancer patient. They should be advised of the possibility of genetic testing and certain ethnic groups, particularly your Ashkenazi Jewish ancestry. That's it. Thank you very much.
Thank you very much, Dr. Pam Patdu, for that very enlightening presentation. So this topic is actually very interesting for me. Even though I am a subspecialist, I have trained for pediatric surgery. As a female surgeon, I still see a lot of breast cancer patients and patients with breast masses. Allow me to let's answer first the questions that were fielded to us by our audience. No, they're actually very simple. So the first question, Dr. Patdu, is actually not related to BRCA. No, it's about, I think, maybe the relationship of hormones to breast cancer and ovarian cancer. Kasi ang question is, posible po bang magka-ovarian cancer pag nagpa-family planning with implant? Siguro yung mga contraceptives. I think that's the question. Let's answer that siguro, Doc. I'm sure kayang-kaya mo yan.
Of course, you can still have ovarian cancer in the setting kahit mag-family planning kasi yung mga predisposing factors for ovarian cancer, let's say genetic predisposition, other factors are still existing in this patient. So it's possible to still have ovarian cancer. Hindi siya parang preventive measure in a way. And yeah.
Okay, yes. Thank you for that question, sir. And then another from an anonymous attendee. His or her mom underwent MRM yesterday lang daw, invasive ductal carcinoma. So what will be the significance of BRCA testing with regards to her case? Sana natin ano kung yung age niya.
So several things that I would like to know will be yung ERPR status niya, yung age niya, and the other things in her history. But for now, based on this alone, BRCA testing would have offered her an opportunity to do concurrent prophylactic mastectomy kung kunwari before the surgery nagawa. But even now, if you know it later on, it can still be offered even after, let's say, the series of treatments, we already also mentioned what one of the more known risk-reducing strategies, your salpingo-oophorectomy, because of the increased risk also for ovarian cancer if you have BRCA mutations. Also, for your mom, in terms of planning adjuvant treatment, if she is at high risk, so traditionally we've heard of adjuvant treatments in using chemotherapy, radiation therapy, and hormonal therapy. Now, for triple negative breast cancers and your HR positive, HER2 negative breast cancer, there's an addition already to that armamentarium, particularly limited to those who are at higher risk. So, a lot of lymph nodes, who have residual disease, should they have had chemo prior to the surgery, and then there's still breast cancer when the tissue was examined. So these are the subsets of patients who will likely benefit from a drug, a class of drugs. Particularly, what we have available is olaparib, your PARP inhibitor.
Okay, thank you, Dr. The next question, yun na nga very basic naman sila eh. So, may I ask daw if there is a relation between breast injury and possible cancer formation? Very common question yan sa atin, Doc, di ba?
No conclusive evidence for that po.
Yeah. Thank you. And then, very simple question about male breast cancer symptoms daw. It's mass. Are there other things that might pinpoint or something that is parang peculiar to patients with male breast cancer, Doctora, in your practice?
So I agree. So ganun pa rin, the most common presentation is a lump in the breast, no? In my practice, what I see in male breast cancer patients, a lot of them have early breast cancer. Probably because it's easier to spot that mass in the breast. A lot of my patients are hormone receptor positive. As a side note, what is peculiar to them, I previously mentioned, if you have male breast cancer, these patients should be advised of the opportunity for genetic counseling and genetic testing because they have a higher chance of having the BRCA mutation. In my practice, a lot of these patients would say, yes, doc, I understand there is that opportunity to test, but I do not want to know.
Oh, talaga?
Once
Sige,
we
going back, talaga takot sila. But going back to not the testing, Doctora, you said earlier that it's available in PGH. But how much is it ba?
So for PGH, I think NIH has I think NIH is the one doing it. But
Mhm.
I'm not too familiar whether it's commercially available. Maybe Sir Dennis can help us out. But for the commercially available ones,
Yes, yes.
maybe 5 years back, the testing would be in 150,000 to 300,000 before.
Ah.
Maybe 3 years ago, it's 75,000. It's now around 20 to 30,000. So
Okay, sige.
it's important to note that we don't usually now just do isolated BRCA1 and BRCA2 mutation testing. Often, itong mga 20 to 30,000 is already a panel of high penetrance genes that increase the risk of breast cancer. And so yung mga STK, PALB2, nandiyan na rin kasama dun sa testing. So it's much cheaper now. And it's a very good thing because a lot of patients can potentially have improved survival if we offer them itong targeted treatments if they are eligible. No?
Yeah, that's right. Do you know of any HMOs, Doctora, that cover this? Your patients, have you encountered anyone with HMOs? Tapos is this covered?
So because most of the HMOs, their restrictions will be for screening per se. Now, some of my patients would have coverage. Siguro depende dun sa nag-a-assess. But in the context that it has implications in terms of treatment, no?
Aha.
It's easier to have it approved if the testing is done in the hospital, no? So maganda if you have access
Inpatient.
in the hospital, mas madali yung approvals for that. And it's easier to justify because it has therapeutic implications now.
Oo, tama. Yeah, that's right. Doctora, yun, in this day and age of UHC, what is your opinion? Do you think that these testing, no, kahit medyo prohibitive ang costs nila, should this be considered as something that will be made available to our patients? Or siguro, what particular subset of patients do you think? Or siguro it has to be a very select group, no, because it's still pricey.
I think it will be easier under the UHC to have approvals for those who have therapeutic implications. Remember, you can have very early triple negative breast cancer and not be recommended to, let's say, have olaparib. So given the processes now, HDA processes, no, I think the ones who are eligible for, let's say, olaparib will be the high priority in the context of the UHC.
So I think you already have an idea, no, of your recommendations for this testing. Thank you so much. This one patient wants to ask if a patient has a history of mastitis. Does this make her high risk for developing breast cancer?
In general, cancers would have increased risk with inflammation, pero yung link niya, directly siguro, I would say sparse data.
Okay, thank you. Okay, we have a patient here, no? She is ERPR negative, HER2 positive, status post-mastectomy. And her biopsy daw showed complete pathological response after neoadjuvant chemo. So she is scheduled to undergo adjuvant therapy. So she wants to know if BRCA testing will help.
Sorry, what was the ERPR HER2 profile?
ERPR negative, HER2 positive.
HER2 positive. Okay.
Yes.
Context, the chances of germline BRCA mutation testing is very low. So I would not prioritize that in study.
Sige.
But of course, you have to look at the context of yung mga family history. Pag high risk talaga, then there might be some benefit in terms of yung testing sa family. No? Baka siya yung less than 1% doon.
Pwede. Sige. This one of our audience, in one of our audience daw yung he has a 93-year-old patient who underwent wide excision biopsy. It turned out invasive ductal carcinoma. I think because of the age, siguro. What is your opinion if it's, a very elderly patient with invasive ductal carcinoma?
Sorry, what to do afterwards?
Yeah, a wide excision was done lang for this 93-year-old.
Sige.
Pero ano pala, this patient who is 93 years old underwent wide excision and her PET scan showed that she has mets in the spine, the ribs, and the pelvis.
Sige. Because this is an elderly patient, no? So, of course, the priority is to know the ERPR HER2 status, given the profile of the patient. Elderly, mostly bone mets. I would think this patient would likely have hormone receptor positive disease and HER2 negative disease. So I think she will still benefit from further treatment, particularly of your hormonal treatments. If she were stronger, targeted treatments with CDK4/6 inhibitors can also be added onto the hormonal treatment. The important thing is to not stop there and consider these additional options for treatment, because this will likely have an impact in the quality of life of this patient. Of course, bone modifying agents should be given to this patient to prevent skeletal related events. No, yun probably is the one greatest thing that will have an impact on the quality of life of this patient if they were symptomatic or in the future.
So I hope the one who asked that question took notes about the advice of Dr. Pam. Dr. Pam, how about, you're in Manila, we're in the provinces. Where is this genetic counseling available? No? Because we might need to refer patients for this genetic counseling. And actually, this is the first time I've heard about it.
So UP Manila has a program, master's program in genetic counseling. So we can probably link up with them. I have a classmate, UPCM class 2007, Dr. Maam Tumulak is a graduate of that program. I think in genetic counseling, what's good about it is that they can usually do it via teleconsult. No? Number two, a lot of the BRCA mutation testing is available in high precision. And high precision has a lot of presence everywhere in the Philippines. And it makes the testing convenient also. Should they request, or should they need this genetic testing? So, yon.
Okay, thank you very much. And then I have a few more questions na lang. This patient, one of our audience, she said she underwent the wide excision via RBT. I'm not very sure what this is. But I think what was noted was fibroglandular rearrangement reconstruction. Now she's asking if I think that's the biopsy, no? If there's a chance for her to develop breast cancer.
By the histology alone, it does not tell
Nine.
us. But we have to look at the whole of the imaging, the clinical suspicion of the possibility of breast cancer, whether there's a need for rebiopsy or review of the slides. It will depend on the clinical context, I think.
Okay, so thank you. Ayun, Dr. Dennis Sakdalan says, yes, hindi commercially available yung sa NIH, but it's in high precision. High precision that they have several laboratories, but doctor, in Manila. So if people are interested, no, that's where you refer them to high precision. Okay, so I think that's something that people need to know. I have one more question about, that was my question. Sige. Doctor, I actually had a patient before who underwent prophylactic mastectomy because no BRCA, of course, no genetic testing was done. I think this was mga 5 or 7 years ago, but she was on regular follow-up with me, and she would be very conscious about masses in her breast. So I did several biopsies, FNABs, ultrasound. And then eventually, siguro after mga 5 years of her following up with me, one excision biopsy turned out the positive. So, and she has always been telling me that may mga tita daw siya who had marami daw silang may breast cancer sa family. So when she finally had to undergo a mastectomy, she requested for a double mastectomy, which I did. But my question now is, for her, who needs to have the genetic testing? She has I think no further treatments have already been done to her, and actually she's lost to follow up. But I would want to advise her again as to the family members. I think they really need this testing. But so all of the family members.
Okay. So the usual way the genetic counselor should advise it is to start off with a patient. So
index.
there is genetic, let's say you have a pathogenic mutation, it is highly advised that the family consults also for genetic counseling, just as a start off, kahit rin po dun sa patient, it will benefit her in terms of further monitoring, kasi it's not just the breast cancer. So yung options for monitoring for ovarian cancer are there. So yun, annual imaging, so I think she will also benefit. And then kung mayroon siya, then we recommend for the family.
Okay, thank you very much. So as we end this open forum, of course, we'd like to thank our sponsor, AstraZeneca, for helping make this webinar possible. Okay, so once again, Dr. Pat Du, thank you very much. We are grateful for your time and expertise, and we present you with this certificate of appreciation.
Thank you.
So I think we've answered. Thank you very much, Dr. Pam. I think we've answered majority of the questions in our Q&A box. But if you have time and you feel that there are questions that you want to answer, you may do so at your spare time, Dr.
Thank you.
Thank you.
Okay.
So Class 1998 would like to thank those who helped make this webinar possible. The University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and of course, our sponsor for this webinar, AstraZeneca. Thank you very much. We invite all our viewers to join the next webinar on sustainable social development in the pandemic. Our expert speaker will be Ms. Benita Tanyag. She is a social development advocate and practitioner and is currently the head of the Makati Social Welfare Department. The webinar will be held on November 13, Monday, also at 12 noon. You can use the Zoom link to register in advance or use the QR code shown here. To receive your certificate of attendance, kindly answer the evaluation form, which you can access through this QR code. We will also post the URL in the chat box now. You will be able to receive your attendance certificate only after answering the evaluation form. So please ensure that the name you enter in the form is the name format that you want to appear in your certificate. So we hope to see you next time as we continue to unlock knowledge for primary care workers and allied medical professionals. God bless you and stay safe, everyone. Good afternoon.